I also would like to acknowledge the Ngunnawal people, the traditional owners of the land, and their elders, past, present and future. It's a privilege to be back in Ngunnawal country, and thank you for the invitation to the ANU. So I'm going to give this talk, and I've had some assistance from Nicola Fortune, who some of you may know, who used to work at the AOHW many years ago, who's been doing a PhD at the University of Sydney looking at the public health aspects of itchy. And she gave a presentation in Sydney a couple of weeks ago and has kindly allowed me to use some of her slides. We'll come to that. Those are the three Aboriginal artworks that adorn my office. Louise knows one of them very well. So, first of all, I was asked to say something about the WHO family of classifications. I mean, classifications are a fundamental building block for health statistics and are designed to be comprehensive with mutually exclusive categories. They're not terminologies. Terminologies have a different purpose, which I always style as for clinical information, communicating information to people where you need exact knowledge of something for clinical purposes. They're not designed for statistics, but clearly there's a linkage between the two. There are three reference classifications in the family of international classifications. I'll say a little bit more about them in a minute. There are then derived classifications, which are either subsets of those reference classifications or drill down into them in more detail, but come directly from the reference classifications. And then there's a set of related classifications which cover other topics, and I've just given examples there of medicines, primary care and nursing, which are all part of the HUFIC family. Importantly, and I think this has been far too much overlooked in the past, classification should be complementary, and being complementary they should be used together. So you only classify something once, not multiple times, and certainly not multiple times where the classifications are different. And the WHO family is part of a bigger UN family of international classifications, which is run by the UN Statistical Division as part of the UN. So it's part of a big system. These are the three reference classifications: the ICD, the International Classification of Diseases, International Classification of Functioning, Disability and Health, the Red Book, and ICHI, the International Classification of Health Interventions. We're sort of beyond books now, but I keep referring to it as the Brown Book. So just a quick word about the reference classifications. As I said, they're part of a bigger family, but the ICD was developed in the 1890s to classify causes of death, bringing together various attempts that have been made to classify causes of death, mainly in England and France. So the ICD was formed by the International Statistical Institute. It passed to the WHO when the WHO was established after the Second World War, and was extended to morbidity and external causes in 1948 with the 6th edition. The 10th edition was passed by the World Health Assembly in 1990, and this week the 11th edition of ICD is being launched in Geneva at the World Health Assembly. The ICF, the International Classification of Functioning, Disability and Health, was approved by the World Health Assembly in 2001. Am I staying in the middle? No, I'm below the screen, that's all right. It uses a biopsychosocial model of functioning and disability, so it's neither a purely medical model nor a purely social model, and it classifies body functions and structures, activities and participation, and environmental factors. You need all of those elements to describe something within the biopsychosocial model. The third reference classification is ICHI. In 1978, the WHO developed an international classification of procedures in medicine, which was okay as far as it went, mainly surgical interventions, but it wasn't maintained and rapidly fell out of date. It hadn't been used much anyway. So the field has been vacant within the HUFIC for many years. And what happened then, after the 1980s, is countries went off and developed their own classifications of health interventions, mainly for use in hospitals to support case mix systems. and they were mainly medical and surgical interventions. And of course, if everyone goes off and develops their own, what happens? Same as railway gauges in Australia, they're all different, and you can't have comparisons, you can't use what other people have developed. It's a massive waste of resources and effort. But that's the situation the world is in and was in the 2000s. So interventions are the missing link for WHO. While it's part of that trio I showed you a minute ago, it actually doesn't exist. So in 2007, we started development, having reviewed the way the world was. Oh, sorry, no, this is ICD-11. Sorry, ICD-11 also started to be developed in 2011 at the same. That's 2007 at the same time. ICHI. There's too many numbers, aren't there? 2007 at the same time ICHI development started. There are a lot of new developments. I urge you to have a look at the website for ICD-11. Interestingly, it has a foundation layer from which ICD-11 for statistical purposes, for morbidity and mortality, is drawn, but the foundation layer is much broader. Some people have compared it to SNOMED, if any of you are familiar with SNOMED. Probably isn't quite yet, but it's certainly a very broad description of health diagnoses, and more broadly seeking to include other parts of the of health as well, including functioning and interventions. It hasn't yet, but that's its ambition. It's also introduced extension codes. You'll hear more about them, but that's a way of adding detail without having something built into the classification. You can add detail through what's called post-coordination, rather than having everything pre-coordinated in the classification. It enables you to have a manageable classification. And importantly, there is this promoting of using the classifications together. So that's, as I said, being released this week. Who manages WHOFIC? This is partly for the AIHW people to make sure I said all the right things. WHO is the custodian and owns the IP of all the WHOFIC classifications. It has a network of about 20 collaborating centres across member states, and the network itself has a series of committees and reference groups, which I think now number 8, 9, something like that, which cover all the topics that should be covered. Now, the Australia has a collaborating centre which is hosted by the AIHW and includes many interested organisations and individuals, including the ABS and the NCCH, my centre. Now I'll talk a bit more about ICHI. So the ICHI journey began in 2007. We took stock of what the world was in 2007 when we met in Tunis at the end of 2006 as the WHOFIC network. First of all, there was no usable international classification. So many countries were left without a classification, even though there were so many national classifications. Only the American one, ICD-9-CM, was in the public domain, and many countries had adopted that, although Australia had managed to sell its classification to a small number of countries, which has expanded a bit over time. Because of that proliferation, international comparisons were difficult. The OECD and Eurostat had developed a set of 36 sentinel interventions. It took them about 3 years to do that and to get a map from all the national classifications to those 36 interventions. And they are strong supporters of the ICHI development. So we started to develop ICHI, and the famous first event was in 2007 when 5 people met in a basement in Freiburg in Germany. Some of us are still working on the problem. Now, after 11 years, we have a beta version. I'll give you the address in a little while. It's been developed from initial content in 2011, once we got a structure together. And there's been a lot of reviews and updates, but this is the first year we've been brave enough to call the version a beta version, that we think there's enough stability for people to actually now test it seriously. It uses extension codes, so you can drill down with more detail using extension codes if you wish. It's ready for testing and systematic review, and I'll say a little bit more about tests. and please ignore any older versions you happen to come across. So from the outset, ICHI was to have a broad scope. We did not want just a classification of medical and surgical interventions. And this slide has really been unchanged now for many, many years. It was designed from the outset to cover all sectors of the health system, including acute care, of course, primary care, allied health and rehabilitation, assistance with functioning, prevention, public health, and traditional medicine. We haven't really succeeded very well at traditional medicine for a variety of reasons, although there are now some acupuncture interventions in the classification for the first time now. But the other areas we've made a lot of effort in, and we think we have some pretty good content. But please keep in mind that broad scope. We developed use cases. I've already touched on those and I won't dwell too much on these, but the international comparisons is clearly one of those use cases, and one that appeals to member states of the WHO who already have national classifications, because they're all interested in international classifications. So if they can map their national classification to ICHI, then you've got easy ways to get to international comparisons. National uses, first of all, for countries that haven't got any classification. I just had the opportunity to present ICHI to the South African Ministry of Health, a country that does not have a national classification, and they're very interested in that. And they're also suffering from the problem of people having picked up different classifications from different places, so the bits of information they've got in South Africa are not comparable. So they can immediately see the value of ICHI. But of course there are many countries in the same situation. There are the countries that have used ICD-9-CM that I've already mentioned. ICD-10 PCS is the new American classification, finally brought in 2014, and some European countries have decided to pick that up. It has 72,000 medical and surgical interventions compared to about 5,000 in 9CM, so they're going to have a lot of fun with that. There are countries that have a national classification like Australia. A lot of national classifications, including Australia's, have some problems. The Australian one is limited in size because of its block structure. One day the countries may decide to redevelop those classifications, and some countries are more actively thinking about that than others. We hope they will use ICHI as a base, or they could use ICHI directly, but at least use it as a base and make sure that the structures and so on are the same. And then you can take, the other thing you can do is you can take the additional content from ICHI and use it to add to a national classification. They're mainly about medical and surgical, so you can take interventions on body functions, activities, participation, domains, the environment, or health behaviours, and use them in your own classification. We're interested in looking at how the interventions can be used alongside the Sustainable Development Goals, the indicators for Sustainable Development Goals, and also the Universal Health Indicators, the WHO. We're interested in how you can use it for patient safety and quality applications, because there's a lot of interest in that. It's normally interventions that result in harm in the health system, and the harm is normally solved by an intervention. So using ICHI for those purposes on the way in and on the way out, if you like, is a very positive use case possibility. And then there's the whole way the health system performs, the way it performs clinically, clinical pathways and those sorts of things, financially, including case mix and general management issues. So there's a wide variety of use cases. We probably haven't got all of them, but there's a wide variety that we're using in our communication about it. Now this is the definition of a health intervention. This was argued over at some time, but it's very broad. A health intervention is an act performed for, with, or on behalf of a person or a population whose purpose is to improve, assess, maintain, promote, or modify health, functioning, or health conditions. So as I normally sum that up, cleaning your own teeth is not a health intervention. Cleaning someone else's teeth other than your child, your healthy child, is a health intervention. So it's a pretty broad spectrum included in the definition. What we've done is we've developed it as a multi-axial classification, which is different from ICD and ICF. It follows a structure that was developed by the International Standards Association in the 1990s and actually followed by France and Canada, who developed their national classifications fairly late in the piece. They also have multi-axial classifications with these three main axes: target, action and means. So the target is the entity on which the action is carried out. The action is the deed that's done by someone to a target, and the means are the processes and methods by which the action is carried out. And it looks like that sort of simple three-dimensional diagram. The organising principle is what is done to what target and how. And importantly, ITCHI does not do a whole lot of things. First of all, it doesn't classify the reason for the intervention, which you classify using the ICD for a health condition or the ICF for a functioning limitation or restriction. That's part of using the classifications together. It doesn't cover the provider of the intervention. That's not fundamental. Who does it is not fundamental to what's done. So we haven't tried to include that, as well as the fact that there isn't a ready classification of health providers, although there is some within the International Standard Classification of Occupations and also industry. We don't cover the setting of the intervention, where it's done. Louise is an expert in settings for health interventions, but we have not tried to do that because there is not an international agreed nomenclature for health settings. And then again, it doesn't cover the outcome, which you can cover by using ICD and ICF. So each intervention is a unique combination of categories from the three axes, but not every possible combination of the three axes presents an ITCHI code. So it's a subset of all the possible combinations of the three axes, and many of them are designated by common clinical titles, which would be familiar in particularly in surgery. The example we've given there is a cholecystectomy, but the axes are defined clearly and uniquely for that intervention. Now, I've mentioned extension codes a few times. If you want to add more detail to an intervention, you can use extension codes. We always realised that devices were a key part of interventions, both therapeutic products, which are internal devices, if you like, but the boundary between internal and external isn't too clear, so we've used the term therapeutic products. Assistive products, which are products external to the person, particularly to offset functioning limitations, and then drugs. A lot of interventions involve drugs, so that's another extension code, which is in fact linked back to the ATC, the WHO's classification of medicines. Assistive products, I'll say a little more about these quickly, but there's some other extension codes mentioned, and one that is not there is telehealth, that we've also now added to that list. So again, it's like ICD-11, and if you become familiar with ICD-11 or ITCHI, then you should find the concept familiar in the other classification. This is the content model, which is the sort of the structural way of presenting all the information domains in ITCHI, with the three axes: target, action and means. Each intervention has a title, a unique axis combination, a textual definition, and then a set of inclusions, exclusions, code also notes and so on. And then the extension codes are listed there at the bottom, and that list of course goes on and on and on. So that's the formality of ITCHI. Now what we have to do with extension codes is we have to know how to link them to the base code in ITCHI, what we call stem codes, and to do that you use an ampersand, the and symbol, which is there in bold between the ITCHI code and the extension code. If interventions are performed together, which is common, particularly in a surgical setting, but in other settings as well. You can link two interventions using a dash. And then if you have a package of interventions where you decide to do a range of interventions at different times, which is common in rehabilitation, mental health, which is probably the only mention of mental health, Louise, I'm afraid, or in public health, importantly, then you can use a plus between them. So we think that's a common, will be a common usage of ICHI. We won't try to pre-coordinate, if you like, packages within ICHI. We'll invite people to use ICHI as building blocks to describe their package. Assistive products, I probably don't need to dwell on this too long. There is another classification of assistive products, ISO 9999. Unfortunately, if you go and look at that, you'll be asked for €200 very quickly, and we thought that wasn't an appropriate list to have within ICHI, which is meant to be in the public domain. So we've steered away from that and developed our own list. That's unfortunate, and the ISO 999 are not very happy about that, but that's reality, and we hope one day we can bring those two together. And of course, if someone wants to use that classification and has access to it, they're very welcome to, as an extension code. Therapeutic products, again, we've had to develop our own list. There are term sets of thousands and thousands of implanted devices, but we've tried to have a simple list. We're not trying to have a fully descriptive list, and that would be, if you want to do that, you'll need to go and use another set, but this is a way of giving you a broad top layer of therapeutic products. It's about 130, it's not that small. Now this is the classification in 2018, the stable version I mentioned before. It includes an introduction and guidelines for users. The reason for that rather complex address is that the platform has been developed by the University of Udine in Italy, and that's why it's UNIUD. I won't give these slides to Luis, by the way, so you'll be able to get the address if he distributes the slides to people. I think if you go into the browsers and look for ICHI, you'll find this fairly easily now. But it's a very user-friendly platform. It looks pretty much like the ICD-11 platform, and there is work now underway to convert it to a WHO platform and to put it on the WHO website along with the ICD and the ICF. ICHI, the ICHI beta version has 27 chapters. The first 12 are body systems and functions. The body systems covers the normal traditional medical and surgical interventions, but at the end of each chapter there is a set of interventions on body functions using the body functions domains from the ICF. The activities and participation chapters, 9 of them, the same number of A&P chapters there are in the ICF. We've used all of the A&P domains from the ICF down to 4-digit codes as targets in ICHI. So this is a really good example of the classifications being used together. So if you've described someone's functioning using ICHI, you can immediately find the relevant interventions that relate to those domains you've used to describe the functioning. The environment is in chapter 22 to 26, again using the 5 chapters of environmental factors from the ICF as targets. Health-related behaviours we've had to develop ourselves because there was no classification of health-related behaviours. We'd welcome comment on what we've done, and there is discussion within the WHO group about having a classification of health behaviours. We'd be happy to use that if it was developed, but at the moment this is our own list, and it is of course a first classification of health-related behaviours. And public health interventions generally have targets in those environmental and health-related behaviours interventions. Now I'm going to talk a little bit more about public health, and this is where I'm using Nicola's slides I've mentioned before, and again thank you to Nicola for agreeing to do this. And she had co-authors, one of which is me, I see, which is very good, but also Therese Riley and Stephanie Short, who are her other PhD supervisors. So Nicola asked, what role can a statistical classification play in public health advocacy? What types of interventions are delivered? How does the mix of interventions change over time? Where are the gaps? What happens if the funding is cut? What is no longer done? And how does Australia compare with other countries? When I was at the AHW, we developed a collection on public health expenditure, which we used to publish as a separate publication. I think now it's included in health expenditure, but I'm not sure whether it is. It's certainly not a separate publication anymore. But we had a lot of trouble getting the inputs as to what was spent on public health, but we had no description of the outputs of public health, and that always bothered us that didn't exist. And there were efforts in Australia to solve that problem, but it wasn't solved. So this is really questions that have been around for quite a while, just in Australia. Nicola's approach has been to test the draft classification of public health interventions within ICHI to see how it measures up as a statistical classification and what problems can be identified. And she's found quite a few, both strengths and weaknesses. I'll say a bit about it in a minute. She did 3 elements of research. She coded some data on public health interventions, which she got from South Australia, and with great thanks to the South Australian Health Department for making that data available. The second set of data was Dutch, and the third set were the interventions used by the WHO in its tobacco control initiatives. So having coded some data, she then assessed intercoder agreement and had in-depth interviews with the custodians of those 3 different data sets. And she's now writing up her thesis based on all of that. Some strengths that came out of the research: it is possible to use ICHI to code intervention descriptions. ICHI coded data produced useful summary characteristics of the data sets. Target and action worked well. In other words, means didn't, but that's well expressed. And ICHI was viewed as useful for summarising outputs at whole system level or comparing between countries. So at a very high level, it was useful. But there were substantial limitations. It's difficult to split complex public health interventions into components. She had to do that and was reasonably successful at it, but it's quite difficult to do that, and for the people who have designed those public health interventions to understand the idea of splitting it into its components. Often there's more than one target, particularly a proximal target and a distal target. If you're improving children's knowledge of road safety, this is a real example from the South Australian data, the program was designed to improve children's exercise and physical activity. But to do that, they had to improve their road safety knowledge. So the particular intervention was targeting road safety interventions, but the distal target was road safety, was health, exercise, improving exercise among children. So that's an issue which I think we can structurally deal with within the classification. Some action categories are missing. Some of them have already been replaced because she was using a version that was a couple of versions back. It's difficult to articulate means. Well, I've already mentioned that. And I think that remains a challenge to find how means work in public health. We've got a few, but that's a long way to go. And there was very poor rates of agreement between coders when she did intercoder comparisons. And the reasons for that are not entirely clear. They may have been trying to code at too fine a level of detail. With ICF domains, you can code at the deepest level of detail or the 2 levels above that. And there may need to be better instruction about that. And that was particularly brought in for mental health interventions, but it's a general feature of the classification. This was her diagram. She used a vernier caliper, which I'm told is a modern vernier caliper. I haven't seen one for a long time. Can you use the classification of public health interventions in ICHI as a precision tool? I think the jury is still out on that issue. And she has introduced the idea of epistemic hubs, and I'm not very good at this, but essentially she's saying that the classification can be used in different settings by different people to help them to communicate with each other. It goes back to the international comparison idea. If they can use a common language to describe what each of them is trying to do, it may well give you better opportunities for exchange of information and getting your general act together. That's a new thought, and she attributes that to Kudchenko, who has made that in a more general context, but it seems an interesting idea. So there's still a lot of work to do on public health, and I will end with an appeal at the end to all of you with an interest to get involved. Now back to, that's the end of Nicola's slides. Now back to using ICHI. We have developed a training manual which is now available, and that goes through the background and the need for ICHI, the scope and structure, the sort of things I've been talking about today, how to use the platform, which is important of course, and then how to code using ICHI. So that's a basic training manual. The testing that's going on will also test the effectiveness of the training manual. The beta testing is underway now. After the Family Development Committee meeting in the middle of April in the HUFIC network, we've launched the first phase of testing, which is being undertaken this month and next by about 20 or a few more testers around the world. We hope to get their feedback in, well, people can put comments on the platform as they go along, but we hope to get their feedback finished by the end of June, certainly during July, so we can start to work through it and update ICHI with the view towards getting a Beta 2 version ready for our next annual meeting, which will be in Korea in October. At the same time, the WHO wants to do formal testing of ICHI as they did for ICD-11, using a piece of software of their own and inviting member states to do particular tests of ICHI. And so we're getting that structure ready during these months leading up to October, and also a base list of interventions to code. We've already got a list of 100 top medical and surgical interventions. We have to develop those for allied health and other areas, probably not for public health, but there'll be certainly be some test material there to go through in the early part of 2019. The tests that are being undertaken, some people are coding data they've got in ICHI, some are doing systematic reviews. The physiotherapist, the occupational therapist, the speech therapist, international organisations are doing systematic reviews of the bits of ICHI of relevance to them. Some people are mapping existing classifications or term sets of different sorts to ICHI, and we're also having some translation done in a few countries, not systematic translations, but just seeing what issues arise when you try to translate ICHI. So we're hoping to finish ICHI in 2019 with the formal test in the early part of the year, with that tool I mentioned, which is called ICHI Fit. There's an ICD Fit. I can't remember what FIT stands for, but it's a tool that already exists for ICD. It can be adapted to ICHI fairly easily, apparently. and we hope to release ITCHI for implementation in October 2019 in the way that ICD 11 is being released this week. Once it's finished, we have to avoid the mistake of the 1980s and maintain it, and that's quite a big task. Now, fortunately, the HUFIC has quite a well-developed maintenance network for ICD and ICF, which is just being upgraded with the finishing of ICD 11, and ITCHI will go into that process, that governance process. Behind that, there's a medical and scientific committee to give advice on particular things if that's needed. So there's a structure for governance through an updating committee, and then a scientific advice structure sitting behind that. We also, the WHO is now actively planning to set up a health interventions reference group to add to the reference groups and committees I mentioned before. Now, one thing we've done with ITCHI is we've actually tried to communicate about it, to market it, which has not been done with ICD 11, or not very much done with ICD 11. We're actively doing that to get people to be aware of ITCHI first of all, to interest them in what it does, encourage them to try it, and of course to implement it. There are potential advantages if you try to do ITCHI sooner rather than later, because you can actually get some influence over the way it emerges. And our key communication targets are countries, professional associations, and the WHO itself. Because WHO, as you can imagine, is many, many stovepipes who rarely talk to each other. We have produced a brochure. Sadly, I've forgotten to bring my limited supply of brochures that I've still got, Louise, down here. I apologise for that. When I send you the slides, I'll send you the link to the brochure because you can have a look at it online. But that's just a 4-page A4 brochure with a few pictures. We've tried to make sure cover gender and ethnic and diversity and service setting diversity, but to give something about ITCHI as the ITCHI story. It's been quite popular, and our Korean colleagues got me to come to Korea to talk about ITCHI because they're quite keen on using it quickly, and they translated the whole thing into Korean, which was really good, so they found it quite useful. So, after 10 years, ITCHI is a reality. Well, it's a virtual reality, but you've got to talk it up, haven't you? But to me, we've sort of, to use in Australia, you can use a racing term, we've sort of come into the home straight after a long race. Lots happens in the home straight, lots of horses stumble and various other people some horses overtake other horses, but we're in the home straight, and hopefully next year we'll see it finished. Clearly many people have been involved across the HUFIC network. There is no money budgeted anywhere for ITCHI development. It all comes out of people's existing bundles of money or people working very late at night. We have endless teleconferences, Skype calls, Zoom calls, all sorts of calls. Inevitably in Australia they happen at 10 or 11 o'clock at night. So, in America they happen at 8 o'clock in the morning. So, people are giving a lot of time to this. But it's really been a very interesting and satisfying exercise. That's it. Thank you.